Hello everybody, welcome back to Med School Mind Maps. Today I want to go talk about liver neoplasms. Now we're going to split this up into benign and malignant neoplasms, and we'll go ahead and talk about the benign ones since there's only three. I want to start out with talking about follicular nodular hyperplasia. Alright, so to discuss this one, what you need to understand is that this is just a proliferation of hepatocytes due to a congenital vascular anomaly. So a vascular anomaly occurs, and then hepatocytes kind of proliferate around that, and then it causes arterial hyperperfusion. There needs to be more blood to the hepatocytes, and because you have more blood, you have more oxidative stress, and this leads to hepatic stellate cell activation. And of course, the stellate cells are in charge of producing collagen, and that causes fibrosis and that around the proliferation of hepatocytes, and this produces a central fibrous scar, typically asymptomatic. You can see that this is not associated with serum AFP levels, and typically more in females and then young to middle-aged adults. And then you can obviously see here, here's where the lesion is. So you have proliferation of hepatocytes, and there's your central fibrous scar due to the stellate cell activation. Here's a gross image of it. All right, let's move on. Next, let's talk about hepatic adenomas. So this is another benign neoplasm. It's very uncommon, and it's caused by the use of either OCPs or anabolic androgenic steroids. So it's typically seen in women due to the use of oral contraceptives, and then as well you have a serum AFP level that's normal. So focal nodular hyperplasia and then hepatic adenomas, AFP is normal. Complications that you can see with hepatic adenoma is you can see rupture, which leads to bleeding, or you can see malignant transformation to hepatocellular carcinoma, which we will discuss in a moment. Very small risk. To treat this, you just want to stop taking androgenic anabolic steroids and or oral contraceptive pills. So, hepatic adenoma. The third benign tumor of the liver I want to discuss is hemangioma. Now, this is the most common benign tumor of the liver, and just like its name, it is associated with a bunch of little blood vessels. So, warning, do not biopsy due to risk of bleeding. This one increases in size with estrogen and pregnancy, so also associated with women, but for a different reason. Remember, we had hepatic adenoma was associated with women because of the use of oral contraceptives. This one's associated with women much more because of its link to size with estrogen and pregnancy. These are also very small and asymptomatic, so just remember, do not biopsy. It's most common in ages 20 to 40, whenever women are more prone to increasing estrogen during that time. So let's move on. So those are the benign liver neoplasms, but now let's start off talking with the malignant neoplasms. And I want to start talking off about hepatoblastomas. So hepatoblastomas kind of sounds similar to hemangiomas. And you can kind of relate those similar soundings to the fact that they're both kind of associated with bleeding, right? Or I'm sorry, I'm thinking of angiosarcoma. Okay, forget that. Hepatoblastomas are just malignant liver tumor. And the main thing that you should really worry about this one is that it can grow really large in size, so 25 centimeters in size, and it's very common in childhood. And the reason that is because it's associated with familial adenomatous polyposis, which is, again, a familial heterogeneity tumor syndrome, which you have mutations in the APC gene, remember, which bind to beta-catenin, which prevent cell proliferation. So you have a mutation in the ABC gene, you're going to have more beta-catenin, more cell proliferation, so you're going to have marked tumor growth, preferably in the colon, but it can also present in the liver as well, here with hepatoblastoma. You can also have sporadic causes, so just mutations from the environment, and this is rapidly enlarging, but it can be cured if you can resect it. And you can notice that you have marked AFP. So remember, all the benign tumors that mentioned it, so hepatic adenoma and focal nodular hyperplasia, you had normal AFP, so alpha-fetoprotein. Alpha-fetoprotein is really produced during pregnancy. It's present there in the yolk sac, and it's kind of a marker of embryonic growth in a way. So hepatoblastoma has marked AFP, and it presents the first 2 to 3 years of life. Males are twice as common to get it. And a couple of symptoms is you're going to have abdominal swelling. You can relate the abdominal swelling to how large the tumor is. And it's a malignant tumor, so you're going to have weight loss, a little foreshadowing, but weight loss is present in all of these tumors. And then abdominal pain. So it's up in the right quadrant, so the liver, very large structure, can compress on smaller nerve fibers. That can cause abdominal pain. And then if this tumor ruptures, it can lead to hemorrhage, right? A paraneoplastic syndrome. So paraneoplastic syndrome is basically just a syndrome that is directly caused by the tumor, and that's going to be sexual precocity. That is due to this tumor, hepatoblastoma, which you can kind of consider as a young in life tumor. So you're going to have more embryonic markers. So this is going to have this tumor is going to release human chorionic gonadotropin, and that tumor is going to, or that molecule, that hormone is going to lead to early puberty. So that's hepatoblastoma. Let's move on to angiosarcoma. Now, angiosarcoma is the one I was kind of thinking of earlier. This is the one that's very highly associated with blood vessels. And sarcoma, endothelial cells, angiosarcoma is a malignancy of endothelial cells. And what happens if we take a look at the histo here is that you will have numerous irregular shaped anastomosing vascular channels lined by atypical endothelial cells with highly infiltrative architecture and a pore demarcation. So in the layman's terms, you're going to have blood cells, right? Not red blood cells, but the cells lining blood vessels, endothelial cells. They're going to proliferate because this is a cancer of those cells in the liver, and they're going to form tons of little capillary networks of blood vessels, as you can see here in this histo image. So you have all of these little networks of blood vessels with marked line. They're all lined by atypical endothelial cells. So it's kind of hard to see, but these endothelial cells don't look like normal endothelial cells. They're atypical. All right, so that is the histo. You can see your vascular markers. If you stain it with a vascular marker for CD31 or factor 7, it can show up there. So that's just a little side note. And then if we can look at the causes of this. So again, it's a malignancy of endothelial cells, but how does this malignancy come about? So exposure to some environmental elements. So you can see arsenic, which is kind of a poison, and then vinyl chloride, and thorium dioxide. And of course, there's idiopathic causes or causes that are not known. And then it's present with a little epidemiology with older patients, so 6 to 7th decade of life, and then males are more common than females, as opposed to hepatic adenoma or focal nodular hyperplasia. Females are more common to get that. And then, so let's move on to the presentation that we will see with angiosarcoma. So imagine if it's a very highly dense blood tumor, this, and it's also can grow rapidly. We're going to have poor prognosis. So it's hard to resect because high risk of bleeding, right? So what happens is the liver presents very acutely with jaundice due to increased bilirubin, and this causes liver failure. And then once the liver has failed, then those cells become more necrotic and they become easier to rupture. And then once they rupture, very high bleeding. So not a good tumor to have. And if we look at where that metastasizes most, it's going to be to the bones and to the lungs. And then symptoms are very just more common metastatic malignant symptoms. So you're gonna have upper abdominal pain due to it being in the liver. You're gonna have weight loss, and then you're going to have malaise. Let's move on to cholangiocarcinoma. So cholangiocarcinoma is a tumor. Now we're going to talk about the bile ducts. So remember, you have the bile canaliculi in between the hepatocytes that then drain into the biliary canal, which then flow through the hepatic bile ducts to the common, which then meet up with the cystic duct, and then meet up with the pancreatic duct, and then go to the ampulla of Vater, and then are released into the duodenum. So cholangiocarcinoma is basically a tumor of the bile duct. It can occur anywhere along the biliary tree, so it can be intrahepatic or extrahepatic. I want to talk about the causes real quickly. So first of all, you can have idiopathic causes, so unknown causes of cholangiocarcinoma. But the more ones I want to focus on here are causes due to chronic inflammation of bile duct. And the first one I want to discuss is liver flukes. So the fluke clonorchis, or the nematode Clonorchis sinensis, which is present in undercooked fish in Southeast Asia. So if you see this on boards, it's going to mainly be a patient comes in after recent travel to Southeast Asia or whatnot, and they ate fish, and maybe it was undercooked, and they presented with symptoms of a Clonorchis sinensis and ended up getting cholangiocarcinoma, which then progressed to either intrahepatic or extrahepatic symptoms. So the next one I want to talk about is primary sclerosing cholangitis. So this is an autoimmune condition of the biliary tree, and this can occur anywhere along the biliary tree, as we will discuss later. There's another one, which is primary obstructive cholangitis, which is mostly extrahepatic. This one can present anywhere along the tree. And what happens is you have an autoimmune condition that causes proliferation of the bile duct, which then it closes off and then obstructs it. So you can see obstructed bile there, closing off of the bile ducts there. And this can lead to cholangiocarcinoma. Last one is coloductal cyst, which is just a cystic outpouching of the bile duct present early in life. And this can lead to cholangiocarcinoma, causes bile obstruction. So the histo of cholangiocarcinoma this is an adenocarcinoma, so tumor of glands. And then you can see locations. So extrahepatic is primarily going to be in the, located at the hilum. So the hilum is where the hepatic ducts come together to form the common hepatic duct. Okay. And then it can also be intrahepatic. So again, it arises from epithelial cells of bile ducts. And we're now going to talk about the symptoms of each one. So intrahepatic tumors, will start there first. So if it's an intrahepatic tumor, remember, if you're looking at the liver here, depends on really where it is. So if it's a tumor here, bile is only going to back up upstream. So bile everywhere else is going to be able to flow down, and you're not going to see really biliary obstructive or cholestasis symptoms. So you're mainly just going to have the normal cancer symptoms. You're going to have weight loss, malaise, anorexia, abdominal pain. So mainly just more generalized cancer symptoms. On contrast, if we move to extrahepatic tumors, as you can see, if it's an extrahepatic tumor or outside of the liver, if it's here, it's going to back up all of the bile flowing from the biliary tree. It's like having a tumor on a branch of a tree versus having a tumor on the trunk, and everything has to flow down towards the roots. Then if it's on the trunk, it's going to block everything leading to it there. So that's what happens if it's an extrahepatic cholangiocarcinoma. So as you can expect, you're going to have obstructive cholestasis symptoms, which include jaundice, dark urine, pale stools, pruritus. Quickly go through this. Jaundice is just the bilirubin is backed up into circulation. It leads to yellowing of skin or scleroicterus. Dark urine. So bilirubin is excreted in the urine because it's now in the blood. And again, bilirubin is a black color. It's what actually gives our stool its characteristic brown color. And then because it's actually not in the stool, you're going to have pale stools. And then pruritus, which is itchiness, those bile salts that get backed up into peripheral circulation end up being itchy. And then, of course, you're going to have malaise and weight loss. That's really all I want to talk about. So actually, to treat this, you're just want to do surgery to get this tumor out, and then biliary stenting. So you're going to want to stent that biliary duct wherever it is, open it back up, allow that bile to flow. So the labs I want to look at are increased bilirubin, obviously, and then ALP, GGT. So ALP, which you can also see in bones, but ALP and GGT, so glutamyl gamma-amyl transferase, and alkaline phosphatase, they are increased during biliary injury. So the epithelial cells that line the biliary tree, those get injured, they release these enzymes. So every time you see an ALP or GGT increase, most of the time, GGT can be increased in alcoholic hepatitis, but mainly if they're both increased at the same time, you want to think a bile duct problem. So if you have a cholangiocarcinoma, those epithelial cells are being hurt, they're being changed, you're going to have an increased ALP GGT. Of course, you're going to have ASTLT if the hepatocytes are damaged, mainly in an intrahepatic cholangiocarcinoma. And then a tumor marker that is not specific but can be identified is a CA19-9. To diagnosis, just perform an ultrasound. You can see it on that, or an MRI or CT. Here's what an MRI, here's what CT looks like. So you can see, there it is. There's another view there. And then on biopsy, here's what it looks like. You have proliferation of epithelial cells there. Looks like you have some necrosis. And then you have ERCP, so just do a scope into the gallbladder and you can take a look. All right, so moving on, let's talk about hepatocellular carcinoma. So this is the big one that we're going to discuss here. Mainly the one that you think about when you think of liver cancer. It's due to a cause of many etiologies, mainly hepatitis due to cirrhosis, or a toxin we're going to talk about. So let's first talk about the cirrhosis causes. So the more or less common ones are hemochromatosis. So that is a HFE gene mutation, which leads to decreased production of hepcidin. Remember, hepcidin is in charge of toning down the absorption of iron through the gut. So if you don't have hepcidin, due to the HFE gene mutation, you're going to be able to absorb, you will basically constantly be absorbing iron. And iron, if it's overloaded, will instead of being bound to transferrin, which is the binding molecule that leads it throughout the body to be used for specific purposes, it'll just be free flowing in the body. And iron is very, can cause, it disrupts. It's a DNA disruptor. It can cause mutations. So that's hemochromatosis. That's how it can lead to cirrhosis there. But then you also have alcohol. So alcohol or hepatitis, alcoholic hepatitis can also lead to cirrhosis. Mainly just to think about the cirrhosis video. And then there's other causes, of course. So hep C, which is the main hepatitis virus or main viral hepatitis that can lead to cirrhosis. It's an 80% chance of cirrhosis if you get chronic hep C. And hep B, which is like a 10 to 20% chance. That's also a risk factor. Hep C is most common in the US. Hep B is most common in Asia and Africa. And then, of course, NASH or non-alcoholic fatty liver disease. And then the other cause of hepatocellular carcinoma other than cirrhosis is going to be your aflatoxin. Aflatoxin, B1, induces a P51 mutation, so very big cellular protein that prevents cell growth. And you can get aflatoxin from Aspergillus. Let's now talk about some of the symptoms. But actually, no, before we do that, let's go ahead and talk about the histo. So what hepatocellular carcinoma is, it's in a expansion of the hepatocyte plates. We're thinking cords. So, you have plates lining our hepatocytes, and those plates end up become thickened. And you have atypical hepatocytes with a higher nuclear to cytoplasmic ratio. irregular nuclear membranes, multinucleation, prominent nuclei. So very just like, very much just histo jargon for you have cancer cells. And then you will have eosinophilic inclusion, or hyaline bodies. I would assume that's due to because you have disrupted cytoskeleton. Could be wrong though. And then in the US, of course, we mentioned the HCV risk. Older adults, Hep C risk. Younger adults, it's going to be more Hep B risk. Remember how you get Hep B? It's more due to sex or drugs or vertical transfer. Males are more common to get hepatocellular 4-1. So that's the histo. Just remember the cords become expanded, and that's about it. A higher nuclear cytoplasm ratio, but if you just remember the cords becoming expanded, you can kind of remember seeing that picture. That's very classic for hepatocellular carcinoma. So the symptoms for HP or HCC are going to be, again, the diffuse, just generalized abdominal pain located in the liver with weight loss or anorexia. If this leads to advanced liver dysfunction, you can actually see jaundice or ascites. Remember, ascites is caused due to either increased hydrostatic pressure due to portal hypertension or lower albumin being produced, which is an oncoprotein, and then you'll have nothing keeping the water inside the venous system, and it leads to edema in the peritoneal cavity. And then you can also see portal hypertension due to the tumor invading the portal vein or the hepatic vein, and again, the portal hypertension can also lead to ascites. The common metastasized sites are the lungs. So remember, if it was the angiosarcoma, it was the lungs and the bones. Hepatocellular carcinoma is just the lungs. So the paraneoplastic syndromes are, again, remember these are just syndromes caused directly by the tumor. We're going to see hypercalcemia. So the tumor, just like small cell in the lung, this one produces, or squamous cell in the lung, apologies. This one is going to produce parathyroid hormone releasing peptide or related peptide, which again acts like parathyroid hormone. It's going to increase blood calcium. So that's why you see hypercalcemia. And then erythropoiesis due to the tumor secreting erythropoietin or the blood cell growth hormone. And then, or hypoglycemia due to the liver not being able to process insulin like growth factor 1, leading to the inability of liver of producing adequate glucose or gluconeogenesis due to that marker not being there. To treat this or to work this one up, you're going to see increased AFP with cirrhosis. So that's going to be worrisome for hepatocellular carcinoma. It's not specific for this disease, but it's very worrisome. You can also see it in other syndromes like a yolk sac tumor, pregnancy, or liver disease in the absence of HCC. So it's not sensitive, but it's very worrisome if you see cirrhosis and increased AFP together. So here's a histo image of an AFP or non-AFP hepatocellular carcinoma. So it's just like that nodule of tissue. And you will see the thickening of hepatocyte cords there. All right, so let's move on to the last topic here, which is the metastasis. What happens if you have a metastasis of tumors to the liver? Mainly, they will come from sites like the colon or the lung or the pancreas or the breast. And it will initially be asymptomatic, but then will eventually lead to weight loss, anorexia, and then when it becomes advanced, you have enlarged, hard, tender, with palpable nodules. There's a gross image of mets to the liver or a CT of mets to the liver. And that is all. So thank you all for watching. This has been a Med School Mind Maps talking about the liver neoplasms. Hope you all learned something, and come again for the next video. Well, we will probably be discussing bile duct obstructions, slash maybe or the pancreas.